Good morning, everyone. I'll be talking to you today about early detection and cross-linking kids with keratoconus. Let's start by asking, why is early detection important? Pediatric keratoconus is more aggressive when detected and rapidly progressive than in adults. It's more visually impairing and can cause amblyopia, which in children is a race against time to save vision, and after a certain age, the brain will not respond to occlusion therapy and the vision will be forever lower than usual. Because children cannot express themselves, it's easily missed, causing delay in diagnosis. Early detection can prevent complications such as eye drops and other signs of advanced keratoconus, which are harder to treat later on. Complications can lead to having surgical interventions like PKP, which have a higher risk of rejection compared to DALK in this young age. So when do we suspect keratoconus in a child? When there is rapid increasing myopia, irregular astigmatism, or frequent changes in glasses numbers. Or when the child has ocular or systemic diseases, atopy being the most common in ocular causes, and Down syndrome being the most common in the systemic causes. In Egyptian children with allergic eye disease, prevalence of keratoconus was found to be 34%, mentioned in a study done in 2021. And the mechanism simply is driven by a combination of chronic inflammation and physical trauma to the cornea. Among the genetic causes, Down syndrome has the highest association with keratoconus, ranging up to 15%. Youngest age described was a 4-year-old girl. The mechanism being a complex of mix of genetic predisposition, biomechanical weakness, and environmental stressors. So how do we detect keratoconus in children? Actually, it's not that different from adults, but the easiest, cheapest, and most accessible sign to detect in children is scissoring, undoing retinoscopy, which is done as screening to all children from day one. And this video will illustrate the normal reflex when doing the retinoscopy versus the scissoring. We can see the beam being a straight line in the normal retinoscopy. And it starts to split, showing scissoring when there is keratoconus. Okay, other clinical signs include Fleischer ring, which are iron deposition in the corneal epithelium, Vogt striae, which are central vertical stroma or Descemet's membrane stress lines due to stretching that disappear on globe pressure. Munson sign is where there is lower lid indentation due to conical bulging of the cornea and looking down, and Risotti sign with a cone-shaped beam or reflection of the light on the nasal side of the cornea. Investigation-wise, pentacam and topography remain the most conclusive to detect and follow up progression of keratoconus. Pediatric patients, though, differ from adults by displaying steeper Kmax values, thinner overall corneas, higher rates of severe astigmatism, and the corneal apex is often more centrally located than in adults. So how do we manage a child with keratoconus? The two main categories of management are stopping progression, saving vision, and preventing complications and amblyopia by doing cross-linkage, and hopefully improving vision by doing either glasses, RGP lens, or surgery like PKP, DALK, or ICRs. Today I'll be focusing on cross-linkage. So simply, what does cross-linking do? The liquid riboflavin drops are activated by a beam of ultraviolet light, which strengthens the collagen and corneal bonds, and that results in corneal stiffness, which stops the thinning, bulging, and therefore prevents visual loss. There are two types of riboflavin available according to osmolarity: the isotonic ribo for corneal thickness more than 400 microns, and the hypotonic ribo for corneal thickness less than 400 microns. Despite that, studies showed that both types are as effective and safe to use in both thick and thin corneas. Several cross-linkage protocols are described according to the corneal thickness. The conventional or Dresden protocol used to take 30 minutes ribo application and 30 minutes UV application, while most commonly used protocols nowadays is either the accelerated protocol, which takes 10 to 15 minutes ribo application with 5 to 10 minutes UV application if thickness is more than 400, or the sub-400 protocol for thin corneas less than 400 microns, in which power and duration are tailored according to the algorithm shown in this table. The transepithelial is another protocol which may be appropriate for very thin corneas or children unable to tolerate epithelial removal, but studies show that epi-off, despite being more painful and have longer recovery, but it's more effective and less incidence of recurrence and progression. Post-operative care isn't that different from adults, but with only one difference in that we taper treatment over a longer period of time to prevent corneal haze. Also regarding the protocols, again, they aren't that different from adults. Studies showed that traditional Dresden protocol showed maximum effect, while other studies showed the accelerated protocol and sub 400 are as effective and safe over a 10-year follow-up. But what are the challenges that we face when cross-linking kids? Regarding anesthesia and patient cooperation, the children cannot stay still on doing cross-linkage, so it's done under general anesthesia, especially for younger uncooperative kids, unlike adults. Also, children tend to have more aggressive and wound healing response. This can sometimes lead to corneal haze and taking longer to resolve. Studies showed that children tend to have corneal haze post cross-linking for longer periods than adults, up to 1 year in some cases. Cross-linkage must be done upon diagnosis, unlike adults, because we sometimes in adults follow up and wait for signs of progression. So practically speaking, what do we do when we diagnose a child with keratoconus? Generally, it's not that different than cross-linking adults, but we must control the allergic ocular diseases first, like VKC. Cross-link the child on definite diagnosis, because waiting for progression just wastes precious time. Use isotonic for both thick and thin corneas. Apply cross-linking protocol according to the thickness. And use general anesthesia, especially if the child is younger, uncooperative. Apply the contact lens to the cornea until it heals and taper treatment over a longer time to prevent haze. Complications such as infectious keratitis and corneal haze and scarring or progression of keratoconus were reported, but despite that corneal cross-linkage is safe and effective treatment for keratoconus in pediatric children, nonetheless pediatric patients treated with cross-linking should continue to be followed long-term to document the recurrence of progression. Thank you.
Thank you, dear Dr. Eman, for this very nice, elegant presentation, as usual.